brought to you by Lenox Hill, Department of Neurosurgery. As you may remember, if you tuned in last time or if you're new, this is really a patient-centered, patient-oriented, interactive webinar where we bring together experts in the field of neuro-oncology, so brain and spinal cord tumors, to really address patient-specific questions and patient-generated questions regarding dealing with brain and spine tumors and cancer in general during this kind of bizarre time of COVID. So my name is Randy D'Amico. I'm one of the attending neurosurgeons at Lenox Hill. I'm also the director of neurosurgery at Wyckoff Heights Medical Center in Brooklyn. And I'm super happy today. I've got two very special guests. I'm going to let them introduce themselves. Rick, why don't you go first?
Sure. Name is Rick Komotar, professor of neurosurgery here at the University of Miami, director of the brain tumor program and program director of the fellowship and residency.
Great. Brad?
Great. My name is Brad Zacharia. I'm assistant professor of neurosurgery at Penn State Health, and I direct the brain tumor and skull-based program here, and I direct our fellowship program as well.
Thanks so much to both of you for taking time out to come and hang out with us. Obviously, very strange times. I'm going to go over just kind of the format. We changed it. Previously, there were some issues with Zoom being hacked, and so we were in a new webinar format. And so it functions basically the same way. Everyone is muted except for us, but since it's an interactive webinar, we basically have the ability at the bottom of your screen, there's a chat feature where people can submit questions that we'll do our best to answer. And then we're also streaming this on Instagram Live. And so you can always ask questions through there that'll get brought into us here where we can kind of talk.
Say hello to your Instagram Live followers.
Yeah, hi Instagram Live. Say hi to everyone. So basically, you know, the idea here was that there's a lot of people in the world right now with a lot of anxiety. As a community, you know, we're in the midst of a pandemic that's really changed the way we practice medicine and think about the illnesses we've been treating, you know, for some time now and developing a practice about. And so it's, you know, we felt COVID is not the only thing affecting these patients. And as surgical neuro-oncologists, cancer remains kind of at the forefront of our thought process and, you know, on our minds. And we realized there's a huge population of patients who are anxious to begin with because they're dealing with cancer and chemotherapy and radiation, but now they're just frankly scared. And there's a lot of uncertainty and anxiety over this. And so we're basically here to provide, you know, support, community, you know, sense of community, as well as lend our expertise and experiences to these patients. And so while we wait for questions to come in, you know, I'll open it up to just kind of discussion between us. You know, Brad and Rick, you both run extremely busy brain and spine tumor practices, mainly brain, I guess, for both of you. What changes have you guys seen already? What kind of things are you guys seeing in kind of the era of COVID? You're obviously in different regions.
Yeah. I mean, I think Brad and I have talked about this before. I think the number one thing that is most surprising to me is the lack of brain tumors that are being diagnosed. When the COVID pandemic first hit us, you know, my first reaction was, oh, well, it's not really going to change my practice because brain tumors are brain tumors. They're obviously urgent, emergent. They're not really elective. And those are still going to happen. And I was thinking that my practice and this program would still be seeing a very high volume of brain tumors. But I think one of the more alarming things is that people aren't leaving their house. People aren't getting MRIs. People are not getting CAT scans. All those centers are closed. All the doctors who normally would diagnose these tumors and then refer to Brad or myself or whomever, they're not working. So, I mean, I've definitely seen the number of brain tumors that I personally even see in the clinic or office or telehealth, maybe a third, I think is a very generous number. It's probably a quarter or less, which leads the question of where are these patients? What's going to happen when all this ends? Because obviously brain tumors aren't stopping. They're still happening. Yeah. And as soon as this pandemic ends and people start to come out of, you know, their houses and they start getting diagnosed, I feel like there's going to be a huge wave of brain tumors that do come to medical attention.
Yeah. Brad, what do you think?
Yeah, no, 100%. And I think that's really well said. I mean, you know, the coronavirus hasn't stopped other diseases from happening, and brain tumors is no exception. I've seen the same kind of drop off, even though we're still doing the urgent and emergent brain tumor operations. Even what we're seeing in the clinic, even what's coming through the ER, that stuff is really declined. And I think it's for those very reasons. And it'll be interesting to see kind of what what effects that might have moving forward. And I think the other thing to do would, you know, and this is very region specific. We, where I am, I'm in kind of Pennsylvania, central Pennsylvania is not as aggressively impacted at the moment. So I would say, you know, if you're having symptoms that are concerning, certainly bring them to medical attention, not worth ignoring. That I think there are ways that we've all developed of managing patients with brain tumors, even in the midst of this this virus and this pandemic, and there are ways to kind of do it safely. I know we've all talked about that.
You know, I usually actually start this with a one of the first rules of the webinar is that we implored people that if you're having signs and symptoms, not to ignore them, to call your doctor, go to an ER. You know, we're all still here, even, and your disease didn't go away, obviously, even though COVID's here, and we have ways of keeping people safe. So, you know, going off both of you said, you're both still obviously seeing patients and have a population that you've treated previously. Have you had any communication with these patients? What's the response from them? What are they telling you?
Are you talking about patients once they come in with a known brain tumor?
Yeah, people you've treated previously, or even new diagnosis. You know, what are you hearing? Are they afraid? You mentioned that people aren't coming in for MRIs or not seeing their doctor.
Yeah, I mean, I would say 95% of my visits are all telemedicine. Mm-hmm. So people aren't coming into the hospital anymore. It's all telehealth. And then if they're surgical, their main questions are, how urgent is this? Can it wait until after the pandemic? If it can't wait, how safe is it to be in the hospital? How quick can I get out of the hospital? So those are the questions everyone has. Do I need surgery? If I need surgery, can I wait till after this is over? Should I wait till after this is over? And how little kind of contact can I have with hospital healthcare workers?
Yeah.
Yep.
Yeah, I mean, it's such a difficult question to answer. I mean, we get the same questions from people, and it's hard. Again, I think it's a very kind of region and institution specific question to answer. Kind of what's the risk of waiting on something versus the risk of contracting the disease. What's your risk if you contract it that you'll get really sick? And so those need to be taken into consideration, I think, when counseling people. Same thing. I've gone almost exclusively to telehealth visits. I booked an awake craniotomy and did it without meeting the patient until the morning of. You know, I mean, it's definitely like a different world. It's not the norm, and I think we're all adapting to that. I think, and we've all talked about this as well. I think the telehealth is going to have a huge, I think, ultimately positive impact on how we do it. We all know that a lot of our patients have difficult time traveling. They travel far for tertiary kind of neurosurgical oncology care, and that a remote way of communicating is going to be, you know, increasingly important in the future.
Yeah, absolutely. Here, we'll take a minute to introduce John Boockvar. He just signed in. He's the senior partner at Lenox Hill. How you doing, JB?
Hi, guys. How are you? Thank you guys so much for being panelists today. It's great to get feedback from other places other than New York, even though we've been struggling here in New York for a couple of weeks now. So it's great to have you guys. Thanks for joining.
Yeah, no, thanks to you and Randy for inviting us. I just wanted to comment on what Brad was saying, how he did an awake crane and he met the patient on the morning of. I can tell you that ever since this pandemic started, so it's been 5 weeks, I have not met a single patient. It's a telemedicine visit. I consent over telemedicine. They come into the hospital. I do not round because I want to minimize contact for the patient and for myself. They're in the operating room. I see them. I see their head open. I operate on their brain tumor. The residents round. They go home the next day, and then my team follows up via phone call, and the sutures are all absorbable. So, I mean, I haven't seen a single patient in 5 weeks, but I'm still operating. It's kind of an interesting situation.
Hey, well, you know what? Running with that for a second, do you feel like it's in a way, you know, less, I hate to use the word intimate, but intimate? I mean, you are meeting these people. You're doing telemedicine in a way.
It's not ideal. It's not ideal. It's not the way that I like to practice medicine. You know, prior to this pandemic, I think I probably went overboard. I would see a patient in clinic. I'd round on them the night before surgery. I round on them twice a day while they're in the hospital. Typically it's only one day, but I would round on the patient. I'd see them post-op, obviously, post-operative follow-up. But obviously things have changed. Like, you know, the worst thing you want to do is round now on the wards, potentially get COVID, and now you're out for 2 weeks. Do I think that it's going to go back to normal rounding? I don't think it'll go back to normal. I think I'm still going to round, but the days of, shaking patients' hands, rounding constantly, that kind of personal contact, I don't think it's going to go back to 100%. I'm sure Brad would agree, right? I mean,
100%. Yeah, I think this accelerated a lot of the kind of telemedicine technology and both the clinician and patient acceptance of it. And it's going to really just change. I mean, it's going to change just kind of our lives, I think, in that same way, but certainly kind of in the way we conduct ourselves in the hospital and interact with patients, I think is going to have a huge impact.
Yeah, absolutely.
One of the interesting things that I had to deal with on Friday was a clinical trial patient that had to come to the hospital. And because family members are not allowed to accompany a glioblastoma patient, I basically had to pick her up off the curb from her husband and walk her through the hospital to get through the right destination, and actually escort her back into his car at 4 p.m. after getting our intraarterial drug delivery. So one of the interesting factors is that these patients, which often have high needs, are not being accompanied by any loved one. And so we're having to expend resources that not necessarily include, shaking hands and meeting patients before surgery, but actually helping them navigate a very complicated system in the best of hands when they're well. And you can imagine a recurrent brain tumor patient having needs, whether they're hemiparetic or they're mildly confused. This whole issue of not having a loved one holding their arm the whole way through the hospital is a whole nother aspect of care that none of us ever anticipated.
Yeah,
absolutely. Yeah.
And there's definitely cases that you have to change the way you approach the care based on this pandemic. So, we were just talking about it before, one of my colleagues and I, like, for example, at the height of the pandemic, about 2 or 3 weeks ago, I had a lady who had a pituitary macroadenoma, compressing the optic chiasm, was losing vision kind of subacutely. Obviously can't wait till the end of the pandemic if she's, progressively losing vision. This was right when the literature came out about the endoscopic and the nasal procedures being the highest risk procedures and aerosolizing particles and everyone getting infected in the room. So basically, even with negative COVID tested, no one was going to do that procedure at that time. So we just did a, craniotomy, and we just did old school craniotomy for this tumor because she was losing vision. And so that's an example of, it's a rare case, but you have a benign tumor, it's progressing, it's symptomatic. No one wants to go through the nose because of spreading disease. So you got to change the way that you treat these conditions. And I know Brad uses a lot of laser. I mean, I use a lot of laser as well. But with all the, travel restrictions, you can't get a rep here to do laser. So I had a case a couple of weeks ago that was a perfect case for laser. Couldn't get the Medtronic rep here because of all the travel restrictions, had to do an open craniotomy. So you find ways to take care of these people, but COVID has definitely changed the options because you can't get a rep or you can't go through the nose. And so those are just two examples.
Yeah, I would say the same as, like, if you're on the fence of resecting a Met, for instance, or radiosurgery, I think, this is a thing that pushes you radiosurgery. Outpatient, doesn't use the resources, doesn't expose the patient in the same way or the staff. You kind of do, doing things that take that into consideration.
Yeah. What I like about what you guys are all saying is that, and I think what's reassuring to patients is that there are options, right? We haven't closed the book on this. We're not saying we're not going after your tumor right now. If you're having symptoms, there are ways that we know how to get around this safely. And I think that's reassuring for a patient at home, maybe listening in, maybe a friend, you can tell them, the docs have figured this out to some degree. You feel like that's true?
Yeah, I mean, we actually looked back at the people that our department has operated on since this pandemic started. It's been about 100 neurosurgery cases, all urgent, emergent. The number of people that have gotten COVID is 1%. Yeah. So the chance, you could tell people that the odds of getting COVID are less being in the hospital than they would be just walking to your grocery store. Yeah. Just looking back at what our experience has been over the last 6 weeks.
That's very interesting.
Yeah,
just let you know that there is data out of Italy and Europe where the contagion rate was much higher. So it really depends. You guys are obviously doing a good job, and I just came out of a meeting where in Wuhan, for example, they had dedicated neurosurgical hospitals from the beginning of the pandemic. So neurosurgery continued, and they basically made COVID hospitals and neurosurgical hospitals and cardiac hospitals, whatnot. Where the Italians were flawed is they basically had a huge amount of spread within the hospital systems. And as we now decant a lot of these patients and wait for this second wave, we expect a nadir here in New York by about May 15th. And that is going to be our time where we're building back up our surgical practices. But then June 15th, we're going to get a second wave. In July 15th, we're going to have some seasonality to this. And then we're going to have a third peak on September 15th. So we're going to have this balancing act of how to handle this sinusoidal curve as we head through into the fall. And I think,
you guys testing everyone who comes into the hospital for surgery?
Yes, 100%.
Yeah.
So we have to have one negative test within 24 hours. The question will be is obviously there's going to be a percent of patients that test negative. There's a 30% false negative rate in some of our swab tests. So we assume all patients are positive. That's number one. And two is there's going to be this quote cross-contamination regardless of what we do. Remember, we have a limited number of CAT scanners in the building. You're going to have a COVID patient go to a CAT scanner and could aerosolize in the middle of a CAT scanner and transmit virus that way. So there are fomites all over the hospital that are shared spaces. So the right answer is actually making separate hospitals for separate procedures, but do the best you can. A 1% transmission rate is outstanding. And, obviously we have been filled where our surgical volume is just, it's now starting to pick up again, which is a very scary factor for us because we're still so filled with COVID patients.
Yeah. So you guys actually, sorry to cut you off. We answered one of the questions from the people listening. People were asking about COVID testing prior to surgery. So, John, you mentioned already, obviously 24 hours. What are you guys doing? Are you guys testing in advance? Is it screening, like a questionnaire?
Everyone gets tested, just like John said, 24 hours beforehand. And then if it's an endoscopic in the nasal, people have kind of chilled out. Now they're letting us do it. If you have 2 negative tests. So if someone needs any endoscopic in the nasal surgery, or if you're going to violate any of the mastoid air cells, if you're doing a retro-sig, if you're going through the frontal sinus, any sinus violation requires 2 negative COVID tests.
Yeah, again, I think we're in a little bit of a different position where it just hasn't hit in the same way. So we're not routinely testing patients. I think the idea when we fully start back up with our more elective schedule, I think the idea is going to be to test the surgical patients. But right now, we're not testing patients. We are testing the endonasal patients. We're doing a single test 24 hours before, and also N95, even if negative. If there's no clinical suspicion. So I think it's just region specific. We haven't had that kind of influx of patients in the hospital or in our immediate region. And so I think our just pre-test probability is overall lower. And that's kind of dictated the way we've done things. So it hasn't been quite the same.
Yeah. What about other system-wide kind of practices have you guys seen? Like Dr. Boockvar mentioned, limiting visitation in the hospital. Have you guys seen, less MRIs being done? You obviously mentioned less people going to see their neuro-oncologists, mostly telemedicine. Are there any other things that are happening?
I mean, it's totally stopped. I mean, literally no one is allowed to visit the hospital. The hospital is at like half capacity. We're like waiting for some apocalypse to happen that hopefully will never happen. But the hospital's basically a quarter or half utilized. The rest of it's empty. 1/3 of the residents don't even come to work every week because we want to have a healthy workforce. So the resident workforce has been cut back tremendously. Less MRIs, less CAT scans. Clinic, you're used to seeing, 50 patients a week in clinic, new patients. Now you're getting like 10. So everything has slowed and just grinded to a halt. And it's not just at a hospital level. As we were saying initially, people just aren't leaving their house. They're literally having a headache, having a seizure. They're hemiparetic. They can't button their shirt, and they're like, well, I'm going to wait for this to end. Like, people are just not getting any medical care. It's not just neurosurgery.
Brad, what about you? I know obviously there are very big regional differences here. So Rick, is Miami, are the ICUs not full down there just yet? Are there still space?
Yeah, so we still have space. So as soon as New York started to get rocked, we prepared as if it was going to be the end of the world here. Like everything shut down, you know, unless someone was dying, no surgery. And then we realized within like 2 or 3 weeks that hopefully it looks like we're not going to be in the same boat as New York. And it looks like we've already hit our peak and we're at like literally 30% hospital capacity. The ICUs still have a lot of capacity. We have plenty of ventilators. So we are starting to crank with regular surgeries now. Not 100%, but the goal is to be, we were literally down to less than 5% of our normal department operating capacity. We want to go to about 25% by next week, 50% in a couple of weeks, and, you know, back to normal, hopefully by like mid-May. But again, you know, normal requires patients coming into clinic. Yeah. And I don't think you're going to see the normal volume for many months. I think because even if you say you can do all the elective surgeries, patients need to get diagnosed. They need to get an MRI. They need to see the neurologist, oncologist, whoever it's going to be. It's not going to happen for a while. People are scared.
Yeah, I think that's so true. Yeah, it just relies on so many other disciplines, particularly you know neuro-oncology and neurosurgical oncology. Of course, other people making these diagnoses, picking these things up, ERs running at normal capacity without being overwhelmed with COVID patients, and the neuro-oncologists and the neurologists is starting to see patients at their normal clip. And so I think while you know, many surgeons are probably eager to just jump right back in, I think we'll probably see a much slower kind of re-uptick in some of these other disciplines that, again, I think will show a lag, even though we may be eager to get back at it, may not see that same kind of immediate bounce back.
Yeah. So, you know, I wanted to just point out, we obviously collaborated recently, the three of us plus someone from Rutgers, so Penn State, Miami, Rutgers, and Lenox Hill, and put together, you know, recommendations basically for how to triage patients with brain tumors for the most part. You know, Brad, you were the first author on that. You want to talk a little bit about what the idea was, why you thought brain tumors specifically needed to be addressed?
Yeah, I mean, I think there have been several other groups and people that have spoken on this. There's nothing completely novel. It's just our take, and I think our collective opinions, again, from a variety of specialists who are in different regions of the country at different stages of this outbreak, if you will. Again, pointing out a lot of the things that you've been discussing on the webinar here, which is, you know, how is this impacting brain tumor patients? What are the things that are still safe to do? What are the things that we should be doing or should be considering? And how might this kind of impact these patients? And so it was kind of more just our take on it. Some guidelines for practitioners who may be wondering kind of how to best approach these patients, how to triage these patients. You know, what are the things that maybe can wait a little bit? What are the things that really shouldn't be waiting? And consideration for kind of getting them plugged in with somebody who subspecializes in this, who could address it even in the midst of this pandemic. So that was kind of the initial inception and idea.
Yeah. You know, I agree. It was mainly, obviously, you know, it was published in a neurosurgery journal, so obviously the main reader should be a neurosurgeon in general. But I think it asks, you know, a few questions which I think are important for our patients, which is, you know, just to bring it down to the patient level, people who are actually listening at home, what makes a brain tumor dangerous to wait on versus, say, your back pain? You know, what's the difference between a brain tumor that makes it more of an urgent or a semi-urgent issue than, you know, your run-of-the-mill something else?
I mean, obviously it depends on the type of brain tumor. I mean, there's definitely tumors that can wait. But if you obviously don't know what you have and you're waiting, you have no idea if that tumor is malignant. You have no idea the rate of growth. You have no idea about when symptoms are going to occur. You know, are you going to have a seizure? Obviously, a seizure can be life-threatening. So it's not that all brain tumors are urgent. It's just that any brain tumor can potentially become emergent, and you want to at least be under someone's care so that you're not sitting at home when you have your first seizure and you have no one to take care of you and you can't go to the hospital and something like that arises and it becomes an emergency.
Yeah. What about,
and there's
Brad.
a lot of there's some gray zone there, and I think that's why, again, it's very region specific and surgeon and patient specific. Like, you had mentioned a lady before. I had a similar situation. There's somebody with a slowly progressive cranial neuropathy, like, losing vision and optic neuropathy, or, it's not life-threatening, but it's threatening real significant neurologic function, really life-impacting function and quality of life. And so, again, I think a lot of what we think about is quality of life. And does the difference between doing surgery now or in several months from now, is that going to have an impact on your quality of life? And does that outweigh any potential current risks for getting the virus? And I think, we take all those factors into consideration. I think we all do these things, and we may not elaborate them very well, and we try to patients, but you're taking into account the patient's age and their medical comorbidities. Are they immunosuppressed? Do they have active cancer and are getting treatment? What's the lesion? What's the likelihood of growth? What are their deficits? All these things that we take into consideration to ultimately render a recommendation to say, look, this could probably wait a month or a couple months and we will get another picture, or, we probably really shouldn't sit on this.
Yeah. What about once they come into the hospital? So, Rick, you talked about a 1% transmission rate at this point, or one patient. What are we doing? What are you guys doing to keep your patients safe? I know at Lenox, we've got a few different things. We've got different draping that we're using in the operating room. We have, COVID specific, non-specific ORs. We're separating floors and ICUs. We're trying to get people out as quickly as we can so that they're not staying in the hospital. Obviously, PPE, I think, I probably touched on a lot of it, but are there anything else that, I haven't mentioned or that you guys are doing specifically to keep people safe?
I think, like Brad said, you assume everyone's positive. So they come in, they get a COVID test. Until that's back, maybe a couple hours later, they're in a COVID rule out area. Once that's negative, they're on like a special neurosurgery floor where everyone's been tested COVID negative. In the operating room, our neurosurgery staff is not there during the intubation. We only come in after the intubation wearing PPE. Post-operatively, they're in the neuro ICU, which has no COVID patients right now. Virtually, 90+% go home the next day. So it's just an expedited process. I think that the biggest risk factor are when you do a big surgery and the person's in the hospital for many, many days. Obviously, that's a big risk factor. So when I see someone, if they need a surgery that's going to keep them in the hospital more than one day and it's benign, I tell them to wait. If they can wait. If they're minimally symptomatic, I'm like, wait till this passes. We'll do it in June, not a problem. But if they can reliably have surgery and go home the next day, I'll do it, because I think the risk is incredibly low.
Yeah. Brad, anything else with that?
Yeah, no, I 100% agree. I think, you undergo the assumption a lot of these people are infected. Again, we're in a little bit of a different situation where we're not necessarily testing at people. Again, we're doing symptom screening, selective testing. And again, our hospital really has these patients. It's a low number of patients and they're isolated. Yeah. And so I think for us, the risk in the hospital is relatively low, but we do the same kind of things, same precautions, and are really trying to do both operations that get patients out of the hospital and really trying to push that as quickly as safe.
Absolutely. John, anything else?
I just had an interesting thought that I want to share with you guys. It's actually a research idea. So we actually know that HIV patients are not dying as you think they would from COVID, and it's probably due to their relative lymphopenia. I'd be interested for us to study our glioblastoma population, which are obviously systemically and locally immunosuppressed and have CD4 counts that are very low compared to even at diagnosis. And I'd be interested to know that I would surmise, and this is just a hunch, that like the HIV population, where we're not seeing the cytokine storm from COVID, if our GBM patients who are relatively lymphopenic are not having cytokine storm. And I'm wondering if we as a group should be looking at that. And the reason why that may be important, not because we may actually have a lower death rate than we think in our GBM patients, much like we're seeing a lower death rate in our HIV patients. And perhaps as our consortium can take a look at this idea.
That's very interesting. First I've heard about that, but it's very interesting.
Yeah.
Yeah, absolutely. We should talk. We'll talk more offline. I want to get to, we did get some questions from people, so I want to make sure we address those because that's why we're here. One person asked, do you think the number of brain tumors is going to increase after the pandemic? I think, like you guys said, there's going to be a little bit of a lag maybe in terms of diagnosis, but the number stays the same. I mean, it's standard kind of epidemiology. I think those brain tumors exist. They occur at some frequency. And I think the bigger issue is going to be the rate of diagnosis and the time it takes to get diagnosed and treated. What do you guys think?
Exactly right. I think we're going to be in for a huge surge once this opens up. And we're going to be working overtime to take care of people who are going to be in worse condition than they would be if it wasn't for the pandemic. So you're going to have people that have waited with a large convexity meningioma and they started having symptoms, but instead of having a foot drop, if it's like a, parafalcine meningioma, their whole leg's going to be plegic and now you can't really help them, or, a pituitary losing vision. I think you're going to run into more severe symptoms because people haven't sought medical attention.
Brad, you agree?
Yeah, I totally agree. I think, like you said, there'll be this bump ultimately where patients are going to be coming out of the woodworks, getting diagnosed once everybody, kind of is no longer isolating. And I think we'll see more pathology that's a little further along.
Yeah.
I mean, think about Manhattan alone, right? So Manhattan alone, I mean, John and Randy, what do you think is the average number of brain tumors operated on in Manhattan per week? 100?
Oh, I wouldn't even surmise 3.
Right, I gotta do math.
Multiple thousands.
I
mean, it's gonna be thousands per week.
Per week in Manhattan. How many brain tumors? So you got 5 major medical centers. You guys each do,
I think,
30,
100.
40?
Yeah, look, it's going to be a couple of hundred, and like you said, there's going to be a bump at some point that where I think what's going to happen is, fortunately, hopefully, there's a seasonality to the virus, and the virus tends to quiet down like influenza during July and August. And instead of us all going away for those summer months, we're going to be catching up doing brain tumors.
Yeah.
Yeah.
I mean, all those thousands of brain tumors aren't going anywhere. They're just not coming into the hospital, and you guys can't take care of them. So when it opens up, they have to go somewhere.
Absolutely.
Rick didn't have summer plans anyway.
Lives in Miami. It's endless summer.
Summer's all year round, bro.
Yeah. All right, another question, but I try to wrap these up around a half hour, so we're coming up on the end. But another question is, are we doing antibody testing on staff or patients, and how does that change our plans? I think I don't think that changes our plans that much. But I think what's interesting, kind of a corollary to that question is, what do you do with a COVID positive patient with a tumor who's actively infected? Do you wait 2 weeks? Do you put them through the risk of anesthesia? How do you think you're addressing that?
Unless they're dying, they're not getting surgery.
Yeah.
If you're COVID positive, you're in total isolation. Obviously, if you're herniating and you have a blown pupil, that's very different. But unless you are life or death, if you're actively COVID positive, you got to wait until that runs its course.
We're doing 2 weeks at Lenox at least.
Yeah.
If you look at all cancers, all patients with cancer, whether it's breast or pancreatic or brain, if you have COVID and you undergo procedures with covidity and cancer, the mortality is something astronomically high, somewhere in the 40% range.
Yeah.
So if you have the 2 C's at the same time, you don't get a procedure.
I actually just saw a paper about subdurals out of Italy, and the mortality rate was like 80% for subdurals in the setting of COVID that were operated on.
Yeah.
So yeah, I think that we wait. In terms of the antibody testing, it's just not available yet. And so we're working, I know, at Lenox to get that available for our staff. JB and I talked a lot about an idea of his, which is basically, the COVID recovered responders, which is once you get, presumably practitioners who are immune to the disease, or at least have antibodies, even though we don't know that they provide immunity yet, you now have a group of people that can go to the front lines, actively get back to work safely, presumably, and get things back on track. Do you guys have antibody testing yet? I imagine.
Yeah. I got tested hoping to win the lottery, and I was negative.
The last thing, I wanted to touch on was obviously, there's a lot of talk now, especially, with Cuomo and his daily reports that, and it sounds like you guys as well, that we have effectively started flattening this curve. And so, we've talked for the past half hour about a lot of the changes that we've kind of made and we've seen in medicine in the hospital system. What are those changes do you think are going to be permanent? What's going to linger for a while? What are things that, are going to continuously kind of affect us in the short term and long term after this? What does recovery look like?
Slow. Very slow. It's not it's not going to be flipping the switch. It's like you're going to allow elective surgeries, and then you're really depending upon the public having a sense of security to go to the doctor and go to the CAT scanner and go to the MRI. That's going to take months. Especially the older population, which is the ones that tend to have medical issues. They're just not going to be leaving their house. So I think it's going to be a slow recovery. And just like John said, there's going to be, a cyclic nature to it. So it's going to be 2 steps forward, 1 step back, 2 steps forward, 1 step back. And normalcy is not going to be the old normal, but probably 6 to 9 months from now.
Yeah.
Brad, what do you think?
Yeah, completely agree. It's going to be a slow burn. I think getting back to normal, and that normal is going to be a new normal. It's going to be very different. I think how we conduct things. I think things that we were talking about earlier are going to be permanent changes. I think telemedicine is going to supplant a huge portion of our visits. I mean, I can't imagine going back now to these in-person visits for a lot of the things that we were doing where it makes total sense. Some of these follow-ups where patients were traveling 2-3 hours for a post-operative visit. We're not going to be doing that now that we have the technology and people kind of accept it. I think that's going to be one positive thing that comes out of this, is that kind of change in rapid adaptation. And I think we're just seeing the beginning of that. But the actual changes to our hospital procedure, to getting back to kind of normal kind of routines, is going to be slow.
Absolutely.
Hey, Randy, the other question I wanted to ask, you, John, and Brad, how are you guys dealing with your residents? Because I think that's a very important topic with COVID. So, for example, for us, just to give you our perspective, we want to keep a healthy workforce. And obviously, if one resident gets COVID, very quickly, a lot of residents can get COVID, and all of a sudden your entire workforce gets kind of is sick. So we have a rotation where 1/3 of the residents every week are out. So only 2/3 of the residents are working. No double scrubbing. Only 1 resident per room. Rounding is kind of limited. But the question is, if this goes on for a long period of time, how does that affect resident training? Especially if you're a chief resident, you're missing several months of kind of key operative experience. I mean, what are you guys doing with your fellows, your residents, training?
Randy, you want to take that, or you want me to handle it?
Well, I mean, you're more involved with the Long Island group, so why don't you can talk about the residency group at large.
Right. So first of all, the whole staggered work from home plan is the right approach. And we started that within the department really right away. So you have only a certain group of people that are exposed at any given period of time. You have to remember the average age of a resident is somewhere between, 30 and 40, let's say, right? So we definitely want, in Northwell, the Northwell Neurosurgery program, which is 2 MDs per year, we were Northwell is treating about 4,000 COVID patients each day in every hospital across the system. So some of our residents were redeployed. Most of our residents are still on neurosurgical services. And actually, one of the research is actually still considered an essential service. So if you're on research, the governor has put research as an essential service, much like a nurse or a policeman. Basic science research is still considered essential. So we actually haven't obviously redeployed our chief residents. They are manning the fort and making sure that they still get the operative experience. We did an AVM yesterday. We're doing an infratemporal fossa approach Thursday. Obviously we want to do these cases and get our residents involved. But unfortunately, from an educational perspective, I'm doing more Microsoft Team webinars with my residents. And even this call is going to be durable. We're going to do this now more and more as colleagues. And I think the cross-fertilization that is going to occur because of this improvement in communication is going to be terrific. And, you know, a system like Northwell that has 23 hospitals and 77,000 employees, I'm communicating with people in Long Island sitting here in Manhattan better than I ever had. So I think it's actually going to do terrific things for resident education. Obviously, it's going to, like you said, Rick, it's going to take time to get back to normal. But the junior faculty, the junior residents, some of them have been redeployed. Most of them are still operating in neurosurgery. And actually, none of them are essentially staying home because we need every person in the workforce right now.
Yeah, it's a different situation. Yeah.
Yeah.
Brad, have you had any limitations in residence?
We've done exactly like you guys both have. We're going kind of half staff, kind of splitting the workforce in the same way. We haven't had any residents redeployed again. That's just kind of really largely based on kind of the low volume of COVID cases here. But taking a very similar approach, and again, echo what Dr. Boockvar said. I mean, very similar. I think of the positive things that are going to come out of this is increased communication. I mean, I think we've all seen just really the explosion of webinars, Zoom meetings, online seminars that are being given by kind of experts in the field. Everybody has probably a little bit more time on their hands for some of these pursuits. And I think the residents at large are going to be kind of reaping the benefits just from a didactic education perspective, and also this increased cross-pollination where we're all able to kind of interact in real time or semi-real time better than we really ever have. So I think that those are going to be some positive things that come out of it from an education standpoint.
Absolutely. And there's tons of new technology that's helping this too. You know, the webinars, obviously we can do all of our conferences online. You know, there's a lot of people looking at virtual reality, augmented reality. I think the majority of recovery from all this is really going to, embrace technology and, app-based, tech, internet tech obviously changes the game from, 1918 when they were dealing with the Spanish flu. It's a very different game now. So I think, neurosurgery in particular happens to be a group that I think embraces technology quickly. And so
I can tell you, there's one thing I'm going to give you guys, you younger guys, an idea. Now is the time. And Rick, you said this. If there is a time in neurosurgical history where the robot has to be used for endonasal approaches, now is the time.
Yeah.
So the robot is poised to take over all airway surgery. When we looked at the robot, and I do robotics with our thoracic surgeons, now is the time. If there is ever a time for somebody to take the bull by the horns, it's not going to be me. Someone's got to use the robot for endonasal surgery. This is the perfect opportunity to do that. So you have my blessing, guys, and go do it.
Absolutely. All right, guys, I don't want to waste too much of your guys' time. I know you guys are super busy. I wanted to thank you guys, obviously, for coming on. I think it was really enlightening, actually. It was a good session. I think learned a lot about what's going on regionally, which is important too. And obviously two very busy services. So seeing, how you guys are affected, even though the community you're in might not be as affected is important to see too. A few things just to plug really quickly. There's a cerebrovascular webinar similar to this tomorrow where we talk about the effects of COVID on strokes, aneurysms, which, arguably has a stronger effect. There's a lot more strokes happening right now because of what COVID does to your, to creating coagulopathy, problems with coagulation and clot formation. Dr. Boockvar does another webinar on Fridays. We can post all the links in the chat here. And then just so you guys know also, we record these go on YouTube now, and the Lenox Hill YouTube channel, and these will be accessible. So if you wanted to share it to anyone, it's around. All right. But thanks so much for your time.
Thanks, guys. Thanks, Randy.
Thanks, Randy.
Great.
Talk.
Bye-bye.
Bye.